Second-degree AV block has two types: Mobitz 1, also known as wenckebach, or Mobitz 2, known as Hay block. Mobitz 1 or wenckebach features a progressively lengthening PR interval followed by a non-conducted ventricular beat due to progressive fatigue of AV nodal cells. Mobitz 1 is cyclical and typically features a ratio of P waves to QRS complexes per cycle. For example, 4 to 3 if there are 4 P waves and only 3 QRS complexes in a cycle. Causes of Mobitz 1 or the wenckebach phenomenon again include high vagal tone, and it can again be a normal variant. But it can also come from inferior myocardial ischemia, atrioventricular nodal blocking agents like we mentioned before, mitral valve surgery, and hyperkalemia. Often treatment is not necessary, but in some instances it can cause bradycardia and hypotension, in which case atropine is used. AV blocking medications should also be reduced to the minimum required dose, and if atropine is not effective, then pacing may be required. On the other hand, in Mobitz 2 or Hay blocks, there is no progressively increasing PR interval, only an intermittent P wave that is not conducted. There is sometimes a fixed ratio between the number of P waves for every elicited QRS, such as 2 to 1 in this example, but they can be higher. Mobitz 2 will usually have structural heart disease, often myocardial ischemia or fibrosis. And in 75% of cases, the anomaly is found below the bundle of His, which means broad QRS complexes are generated. However, the defects are in the bundle in 25% of cases, which means a narrow QRS. Mobitz type 2 are often symptomatic as a result of the reduced cardiac output, with syncope, fatigue, chest pain, and in some cases sudden cardiac death. It also has a relatively high progression rate to complete heart block.